Good afternoon. Welcome to the UCSF Department of Medicine Grand Rounds. I want to send a welcome to our live audience from the UCSF Department of Medicine, our other colleagues here at UCSF, and our friends at our partner sites in the UCSF Health Network. I see we already have about 800 participants who have joined us on Zoom. I assume we'll have some more. We will post this video later on YouTube. The Grand Rounds that we did 2 weeks ago, for which this is an update, has been viewed about 50,000 times. So it's clear that the hunger for up-to-date, accurate information about COVID-19 is evident and completely understandable. And I'm guessing that today's update will be equally valuable. First, a few ground rules for our live audience who are joining us. You see them on the screen. Put your Zoom window in full screen mode and adjust the presentation to fit to window. If you have questions, submit them through the Q&A box on the bottom. That box is being monitored by my colleague, Quinny Cheng, and we will try to answer as many of them as we can after the first 4 speakers speak. None of the speakers have any relevant conflicts of interest, and the reason all of us are not wearing masks is that we're all sitting alone in our offices, which is allowed. There is a universal mask policy, however, at UCSF in our clinical sites right now. Why are we doing an update after we did a session like this 2 weeks ago? Because as you know, 2 weeks is a lifetime in this battle, and a lot has changed in the last couple of weeks, as you will see as you hear the talks. Our format today will mirror the one we used 2 weeks ago. 4 of my colleagues will deliver 12-minute talks covering some of the key issues in this pandemic: epidemiology, virology, and testing, clinical aspects of the disease, as well as treatment options. We'll then have about a 15-minute Q&A involving those 4 speakers. That will take us a little past the first hour mark. That will be followed by a 30-minute panel discussion with 5 other UCSF experts. They'll focus a little bit more on the ground experience that we're all having in managing this from a variety of viewpoints. The entire session will last about an hour and 45 minutes. It goes without saying that our hearts go out to the patients and their loved ones who have been affected by this virus. Last week, we lost one of our own, Dr. John Murray, who was Professor Emeritus in our pulmonary division, and sadly and ironically was one of the people who first described ARDS and did seminal research in the disease, and he succumbed to COVID-19 in Paris, where he was living. His obituary was just posted in the New York Times. So this thing is already affecting all of us in all sorts of ways. And sadly, to use a baseball metaphor, we're probably only in the 2nd or the 3rd inning. Before we start, I really want to send my thanks to everyone here in the UCSF community who's responded to this challenge with great skill, commitment, teamwork, and courage. Salute particularly to the clinicians who are providing direct care both here and around the world. Also to our research and educational communities who are carrying on under trying circumstances, and particularly the researchers who are trying to help us better understand this new disease. Finally, a thanks to our leaders who have supported us skillfully in a rapidly swirling and charged environment. All of that has made me very proud to be here at UCSF. Here in San Francisco, a combination of early and aggressive action by political leaders, corporate leaders, including those here at UCSF, and the public, as well as undoubtedly some good fortune, has led to a far flatter curve than we're seeing in many other parts of the country. 3 weeks ago, for example, our case number in San Francisco was essentially the same as in New York. As of this morning, there are 450 confirmed COVID cases in all of San Francisco and 7 deaths. Tragically, the case count in New York has now topped 50,000 with 1,400 dead. It's absolutely vital that we don't let down our guard, that what we've done here in San Francisco has been working and we need to keep it up. And there are probably some lessons from our experience, and that's part of why we're here today. The importance of conducting rigorous science and providing accurate information to both professional and lay audiences have never been more evident, and so that is the aim of our session. Let's start with the first speaker. The first speaker is Diane Havlir. Diane is Professor of Medicine and Chief of the Division of HIV Infectious Diseases and Global Medicine based at our Zuckerberg San Francisco General Site. The goal of her research is to develop therapeutic strategies to improve the lives of people living with HIV and other viruses, now including the coronavirus. and she will start us off by giving us an update on the epidemiology of COVID-19. Diane, it's yours.
Thanks very much. So we are continuing to see an extraordinary expansion in the COVID-19 pandemic. We're going to cross the 1 million barrier over the next 24 hours of reported cases to date. And just 2 weeks ago, when I gave this same talk, we were really focused on the 80,000 cases that we're seeing in China. So COVID-19, a quick review, is a new coronavirus that's related to the SARS virus and called SARS-CoV-2. It crossed the species barrier between bats and humans in late 2019. This virus can infect cells in the oral pharynx, in the upper respiratory tract, in the lung, and the gut. One of its characteristics is that people who are infected have high viral load and are very transmissible before and during symptoms. It can be fatal, there's no treatment, there's no vaccine, and the public health responses are what we have now. Next slide. So let's look a little bit at the global spread over the last month. What are we seeing? So the epidemic epicenter has spread from China, Asia, to Europe and the United States. And although certainly not gone, Asia as the epicenter has really subdued. I think we can say that Asia really had what I would call a SARS-like response. They had experienced SARS before. It had devastating health and very large economic effects to their society. So when COVID-19 came around, they acted fast. They did massive ramp up of testing. They had already had a culture of wearing masks in public, and they instituted already existing robust contact tracing and quarantine systems. So if we look at these graphs here on the screen on the upper left, this maps out daily deaths over time. And what you can see in February, we're seeing these deaths in China. They're reduced, and then we can see that these are numbers of the confirmed cases, not deaths, that are rapidly increasing. First we see in Italy, then in Spain, and then you can see in the United States just this remarkable trajectory. If we look on the lower graph, this is adjusted per population of persons, and this helps one see, at least in terms of reported cases, where the hotspots are, and you can see them in Europe and in the United States. The next slide. Okay, so now let's move on to deaths. The prior slide was for cases, and we have had over 40,000 deaths worldwide. The countries with the highest number of deaths are Italy, Spain, the United States, followed by France and China. We can also look at the trajectory of these deaths, and these are a rolling 3-day average starting in February 17th. And this will surprise none of you because we have all heard and seen the just tragic pictures from Italy where they had a rapid increase in their death rate, followed by Spain and now the United States. Below that graph is a graph adjusted per million persons, and once again, you can see the hard-hit regions per million persons in Europe. Next slide. So when we look at epidemics, we're interested in the case fatality rate, and that is the number of deaths per cases reported. Now, in the context of an active epidemic, these numbers are very dynamic and evolving. People on an individual level want to know if the incidence, they want to know the fatality per incident infection. We don't know that right now. So let's look at the CFRs, or case fatality rate. Right now, the current global range is from 0.2 to 7.7. And in an active epidemic, it depends on the context, the population that's being affected, and the stage. You can imagine, for example, if an epidemic started in an extended care facility with a very old population, the case fatality rate might be very high earlier, but it could decrease as it spread to a population with a lower age. Because we are not testing everyone, we overestimate the case fatality rate in epidemics, which is the case of what we're doing now. I think one thing we can say with confidence, when you look across the globe, and if you look at the graph on the upper left, which shows case fatality rates by age by 4 countries, which are 2 in Europe and 2 are in Asia, that the higher ages are associated with higher fatality. And this is also if people have co-infections. I think we don't have data, as much data from the United States yet, but I think we're certainly seeing, it seems like a lot more middle-aged people being infected with the disease. So we'll see what's happening. I think we can fairly say we are not seeing deaths in the younger age groups. We know that this particular infection has a much higher case fatality rate compared to the seasonal flu. We don't know if it's 10 or 20-fold higher, and we'll get more data about that. And this variability we're seeing will be explained over time. Next slide. So what's happening in the United States? We've got over 200,000 cases and over 4,700 deaths. The virus entered and spread through the United States via airplanes, land, and sea. Our response included rationing testing, and I think it's fair to say that some confusing and variable public messaging and action. And many healthcare workers got infected. We don't know how many. Nursing homes and cruise ships became sub-epidemics, and just yesterday the IHME released a model that predicted in the United States somewhere over 80,000 deaths, and we expect to see this death trajectory increasing over this particular month. We first heard about cases in Washington State, California, and some of the coastal states, including New York. Bob just mentioned the incredible escalation of cases that we've seen in the state of New York and in New York City. We also have other hotspots in the United States, which include Louisiana, and there's been speculation that was post-Mardi Gras, and also in the central United States, Michigan, Illinois, Indiana, and possibly Wisconsin. Next slide. So let's look at California and the Bay Area. We have nearly 9,000 cases in California. This is a heat map, which shows cases per 100,000 people. Just to note, you can see where the Bay Area is. Just to note, the dark region in the central eastern border of the state, that's just really small numbers, and that estimate is not precision, so please don't be distracted by that. Next slide. So there was a really interesting paper by Charles Chu's group, which was recently released, and it addressed one of the questions of what do we know about the introduction of COVID-19 into Northern California? And his group sequenced 29 viral isolates, and what it suggested or showed that there were multiple independent introductions of COVID-19, the SARS-CoV-2 virus, into Northern California. And you can look at this map here. You can see in San Francisco that we had some viruses with the European lineage. We had some viruses with the Washington lineage, which was also on the cruise ship. Solano County had its own lineages that they were seeing, and also there were some lineages from China. So this is how it has, it is not just purely from community spread from one strain in California. Next slide. So 2 weeks ago, we talked about, and all of you have seen this, of trajectories of epidemic and wanting to flatten the curve and the things that we do. And we, around the world, people have initiated population level measures in order to contain the epidemic. And those are based on what we have now is just to try to prevent the viruses, which are in particles, to spread from person to person by keeping people farther apart so they don't spread it by talking, sneezing, spitting, or singing. Or touching surfaces that may also harbor the virus. This is a graph which shows over time, starting in the first day of March, this is only a month, of the absolute number of cases by county. And what you can see here is the top county, the dark gray is Santa Clara, followed by us in San Francisco, then San Mateo, and then Alameda. What I superimposed on here was the dates of action under our mayor and Grant Colfax, the director of the public health department, over time what was done in San Francisco. You can see on March 6th that we declared a local health emergency. There was some environmental cleaning, suggestion of limit of gatherings, and then on March 16th, a shelter-in-place order was released, and then finally the most recent mask for healthcare workers. Next slide. So one of the questions, social distancing and these shelter-in-place measures have been implementing around the world. So one question is, are people actually doing them? And we can actually go to public databases, a variety of sources to get some evidence of this. So I just want to give 3 examples. What you can see if you look at the percentage of people who are traveling compared to what during this time of year they usually do, you can look at these percentages over time. And I just show 3 cities here, San Francisco, Boston, and Chicago. You see San Francisco had the earliest drop in terms of this transportation metric. Also, this is really interesting too, nitrogen dioxide, which is an intermediary in pollution, which really reflects industrial output. There's all these satellite images where you can look around the world and you can see as countries or regions put shelter in place and people were not at these factories working, that there were reductions in NO2 emissions. And then finally, this was just kind of interesting, online purchase of jigsaw puzzles has actually skyrocketed, presumably because more people are staying at home. Next slide. So this is a real key question. Are these interventions enough and are they working? Well, we don't have drugs right now. We don't have a vaccine right now. So the one thing that we are not uniformly doing is recommending the use of masks in the public domain. And of course, this assumes we have all of our healthcare workers protected. There are some data to suggest that these barrier methods, they're certainly not completely effective, but they could reduce transmission and provide some protection with certain types of fabrics. So there's lots of discussions right now around California, around the country about this. And the first actually public health department to make a move was in Riverside County 2 days ago when they put out a public health order and launched a YouTube video with rather a catchy jingle, which was building on what was already being done: stay in place, maintain your space 6 feet, and cover your face. So a couple of cities, Los Angeles has recommended, the state of California says they think it's a good idea. So we'll see what happens with that. In terms of any empiric evidence that these types of interventions work, I showed 2 weeks ago what happened in China with this whole package of interventions that they utilize, which did include public masking. And I just shared this with you. In Italy, these 2 districts, which are similar in many characteristics, adjacent to each other, had 2 completely different approaches and levels of aggressiveness for shelter in place. One started February 16 with a very heavy mayoral top-down order, and then the other on March 9th. And you can see the number of cases, really how they dramatically differed. It's just in terms of we're always measuring cases, and certainly when we're looking at hospitalized cases of what happened 2-3 weeks ago. So we are still trying to understand exactly what is happening in our cities and cities in the United States, but we are going to know more soon. Next slide. So I think one topic that everyone is interested in talking about is what is our breakout plan? Well, if we look at the global experience in China, Singapore, Hong Kong, and Taiwan, they have been easing social distancing. They have not seen a huge resurgence in cases. Part of their breakout plan includes mask use, also rapid and universal testing, isolation and contact tracing, and some border control measures. We must and need to understand the immunity to this disease, and there's a large effort. UCSF is really, I think, leading and coordinating much of these efforts to understand which antibody tests are best, and we can and should be using this as part of our strategies. But let's just say that we find out that the prevalence is only 5%. It's going to be tough because there could be 95% of people who are still susceptible. So we're fortunate we have strong city and state leadership, and we're going to need to deploy these with a multi-sector approach and using the highest tech approaches that we can for some of these rather draconian approaches. So I think we absolutely, the way out of this is with a vaccine, but in the meantime, we need to continue research for scalable prevention and treatment and to understand more about the virus. This isn't going to be the last time with this group of viruses, and have a stronger structure for pandemic response. Thank you.
Great, thank you, Diane. I'm sure the issue of the breakout plan and what happens next will come up in the questions. Let's switch over to Chaz. So Chaz Langelier, who is assistant professor in our Division of Infectious Diseases based at UCSF Health. He also works in the Chan Zuckerberg Biohub. His research aims to understand the biology of infectious lung diseases that influence respiratory infection susceptibility, severity, and their contribution to lung injury. And he has become one of our go-to people as we talk about testing, and that's what he'll talk about with us today. So Chaz.
Well, thanks, Bob. I'd like to start by just saying that testing has really been a cornerstone of the COVID-19 response. It's so important for understanding infection prevalence in the community and also in the hospital, and for preventing hospital-transmitted infections. Next slide, please. Testing has certainly been an acute issue in our country. This is evident if you read the popular press or the scientific press. And one of the key issues related to this was with respect to challenges in terms of test availability. I think many would argue that lack of availability of tests early during this pandemic precluded us from truly appreciating the gravity of the situation and from understanding the degree of community spread. Next slide, please. This is appreciated if we think about tests per capita. If we look at coronavirus tests per million people, we can see that the United States, this was from a week ago, still lags behind many other countries. And testing and test availability remain an important challenge in many locations. Next slide, please. In terms of the diagnostic tests that we have, they involve, by and large, reverse transcriptase PCR, which detects components of the viral genome. And in particular, these tests target two key locations. They're highlighted in red on the slide. A schematic of the viral genome is shown towards the bottom of the slide. They target the N gene, which encodes the nucleocapsid protein, as well as the E gene, which encodes the envelope glycoprotein. Next slide, please. And these reverse transcriptase PCR tests have sensitivity that depends on specimen type. I'll go into that more in detail in a minute. And they're highly specific. Next slide, please. With respect to the latter point, it's important for everyone to recognize that there isn't cross-reactivity with the SARS coronavirus 2 PCR tests that we use with the other 4 common coronaviruses that circulate in the United States and in many other countries. What's shown in the background here is a phylogenetic tree showing the genetic relatedness of coronaviruses, and you can see that there is divergence between the SARS coronavirus 2 and these other coronaviruses. And this is just reflected in the specificity of these reverse transcriptase PCR tests. Next slide, please. So what about testing at UCSF? Well, our university was really one of the first out there to make testing available in-house. This is due to efforts from Steve Miller at Doernberg, Charles Chu, and the Clinical Microbiology Lab. And for the past several weeks, testing has been humming along at more than 100 samples a day. And increasingly more PCR platforms are being employed, in part to help alleviate issues with supply chain problems and in part to deliver faster turnarounds. So what's shown in the picture here is one of the latest PCR instruments to come online. This is a GenMark ePlex. It's actually been deployed at Parnassus. This can detect multiple viruses in addition to SARS coronavirus 2 and can offer a 2-hour turnaround time. So despite the 100 sample per day output, this really wasn't sufficient to meet the demands, not only of UCSF, but of the larger Bay Area community. Next slide, please. And so to address this unmet need, leaders at the Chan Zuckerberg Biohub, Joe DeRisi, and others helped build a partnership with the Clinical Microbiology Lab to extend capacity and leverage liquid handling robots and high throughput instrumentation, as well as a whole team of volunteers to help meet the demands for greater capacity. Right now, there is ability to do more than 1,000 tests per day. These are PCR-based tests targeting the N and E gene, and currently serving many UCSF partners, including San Francisco General Hospital, Department of Public Health, and many others. And this really is one of the more inspiring examples of teamwork and camaraderie that I think we've had here during this otherwise terrible pandemic. Next slide, please. So as I mentioned previously, sensitivity of the reverse transcriptase PCR tests depends on sampling site. And I'll first just start by showing data from the common coronaviruses as we can infer some information from this. Sampling of the oropharynx seems to have overall the lowest sensitivity, nasopharyngeal a bit better. A combination can boost that further. And then a nasopharyngeal wash, which is a procedure done more commonly in pediatrics, but not so much in adult patients, can offer the highest sensitivity. This was based on a composite gold standard of using all of these approaches. Next slide, please. So what do we know about SARS coronavirus 2? Well, no study has been done yet that allows us to accurately calculate sensitivity and specificity, but what we do have are several studies now that look at the percent positivity based on swab type. And we see a similar trend in that oropharyngeal sampling has a lower percent positivity compared to other sites and compared to lower respiratory sites. Now, many of these studies suffered from some bias in terms of patients who received bronchoalveolar lavage likely had more severe disease than some of the others. But nonetheless, this helps provide an indication of what type of sample is the best approach. Next slide, please. More recent data from Hong Kong has provided some insight into lower respiratory versus perhaps more upper respiratory sampling. As was suggested by the prior work, greater viral load that's shown on the y-axis was appreciated in endotracheal aspirate compared to a saliva sputum sample. And I think one of the interesting findings from this study, there were a number, was that viral load was really highest early during symptom onset. And this is in notable contrast to the original SARS coronavirus, where viral load often peaked after symptom onset. And this early high viral load in patients who may have mild symptoms or when their symptoms are just beginning potentially could be an important aspect contributing to the spread of this infection in people minimally symptomatic or asymptomatic individuals. Next slide, please. Some insight into this question of asymptomatic individuals, viral positivity, and whether they're worth testing comes from work examining what happened on a number of cruise ships, in particular the Diamond Princess cruise ship. So on this cruise ship, 19.2% of passengers and crew ultimately tested positive, and notably 46.5% of these individuals were actually asymptomatic at the time of testing. And I think that probably reflects what was demonstrated in the study on the previous slide, is that patients have very high viral loads early during their disease course. Next slide, please. So what are we doing at UCSF with respect to asymptomatic patients? Well, right now we're testing in just a select number of cases. This may change as test availability further increases, but patients are being tested who are asymptomatic for pre-transplant screens for solid organ transplants or bone marrow transplants, patients admitted from nursing homes given the potential public health and societal implications, and in addition, patients from whom a history is unobtainable. Next slide, please. So what about serologic testing? This is certainly an emerging area of a lot of interest. I think it's helpful to step back and ask ourselves, what are the goals of serologic testing, and what is the added value here compared to the nucleic acid reverse transcriptase PCR testing? Well, perhaps the most significant is simply determining the presence and duration of protective immunity, which could really have important implications for triaging the ability of healthcare or other workers to safely return to work. Could also have a role in evaluating efficacy of vaccines and durability of those vaccines. Without a doubt, serologic testing will be key for enabling population-wide seroprevalence studies to be able to determine precisely what the prevalences, and in addition, better estimate mortality rates. And then, as I had shown on the slide, comparing the different test characteristics based on sampling site, serologic assays could help improve the sensitivity of diagnosis. As right now, with nucleic acid testing, really a negative test in someone with a high pretest probability or high suspicion of COVID-19 does not rule out infection. Next slide, please. Within the past week, a number of rapid serologic assays have become available in the United States. I'm showing a general diagram of how many of the laminar flow ones work. This is an assay that's now being marketed by Becton Dickinson. And these assays use colloidal gold nanoparticles that are affixed to part of the strip. If a patient has antibodies against SARS coronavirus 2, these will bind to the gold nanoparticles containing antigens to SARS coronavirus 2, and depending on whether there's IgM present or IgG present, there will be binding at specific locations as a patient's blood sample is flowed through this assay to areas where there's anti-human IgM or anti-human IgG present. And it gives a very similar readout to, let's say, a rapid strep test where there's a banding pattern that can be interpreted. 15-minute turnaround, and in initial reports of this general assay type, reasonable sensitivity and specificity, although these tests have not been broadly validated yet on actual patient samples, and so I think this still remains to be determined. Next slide, please. There was some nice work out of Mount Sinai recently that further advanced our understanding of serologic testing. I should mention that one of the issues with many of these rapid serologic diagnostics is cross-reactivity with common coronaviruses. The group at Mount Sinai was able to build an ELISA that targeted the spike glycoprotein receptor binding domain. That's shown here in red in this model structure. And this ELISA was specific for SARS coronavirus 2, unlike the case for many of those rapid laminar flow assays, and provided significant ability to differentiate between seroconverters and control samples. Next slide, please. I think it's important to consider the role of serologic testing in broader context. So I think it's important to recognize the time needed for someone to seroconvert, and recognize that serologic testing may not be the best choice for detecting acute infections. This is nice work from a paper that recently came out in final copy in Nature, and it showed that seroconversion of 50% of patients in their small study of individuals with mild to moderate disease happened by day 7. And that all patients in this study seroconverted by day 14. So I think that's important to keep in mind. They also had some interesting work and data that looked at the relationship between positive viral culture obtainable from specimens from patients over time compared to simply detecting presence of the virus. And what they found is that in their patients, viral PCRs remained positive for up to 2 weeks or longer, yet after 8 days, no patients in the study had culturable live virus that could be obtained from their samples. Presumably that is a reflection of the presence of neutralizing antibodies in the sample that correlates with antibody response. It's a nice paper. I encourage everybody to review it tonight over Zoom happy hour with friends. Take a deeper dive. Next slide, please. Some of the most exciting developments on the diagnostic front have come online in just the past week. These are rapid nucleic acid diagnostics. Shown on the left is an Abbott instrument called the ID Now. It uses an isothermal amplification approach, and can provide a yes/no answer in under 10 minutes. So this certainly could have potential utility in many settings in the emergency department. One potential concern here is the aerosol generating potential of the instrument, and that has raised some concerns. So it's unclear if that will really be a good option in the ED as it stands without some type of containment. Then shown on the right is the Cepheid Expert platform. This is a PCR instrument, sample to answer, that is available in many labs in the United States and throughout the world, most commonly used for Mycobacterium tuberculosis diagnostics. And this provides an answer in 45 minutes. So I think some important developments here that will really improve our workflow and ability to rapidly identify patients and then implement the necessary infection control precautions and triage resources. Next slide, please. I'd just like to wrap up with metagenomic next generation sequencing, which is a technology that's used by a number of research labs and clinical lab at UCSF. UCSF was actually the first in the nation to bring clinical next generation sequencing online for diagnosis of meningitis. And really the advantage here is that it can take any sample, such as a respiratory sample. It can take nucleic acid isolated from that sample and detect all microbes present in that sample in an unbiased approach. And it was, in fact, metagenomic next generation sequencing that first allowed the world to recognize that this idiopathic pneumonia syndrome taking place in Wuhan was due to a novel coronavirus. I think in the future, we'll see metagenomic sequencing more widely available in hospital microbiology laboratories. So by the time the next pandemic hits, we'll be ready with a test that can identify what's causing the problem. So I'll wrap up there and turn things back over to Bob.
Thank you, Chaz. Really appreciate it. And brings up a lot of questions we will get to. Jen Babik is next. Jen is Associate Professor in our Division of Infectious Diseases at UCSF Health, also Associate Program Director for Internal Medicine Residency, and the person we also always run to with clinical questions. And so we have a lot of them now on some of the clinical manifestations of COVID-19. So Jen, take it away.
Thanks so much, Bob. So what we're going to talk about today are updates in the clinical manifestations of COVID-19. Next slide, please. And just to give you a sense of what we're going to talk about in this section, we'll start by talking about some updates in clinical manifestations, and we'll focus on cardiac, GI, ENT, and ocular manifestations. We'll spend a little time talking about COVID-19 in patients with cancer as a special population. And then we'll talk about an update in US data on co-infections, and then we'll close with some discussion of the clinical course in ICU patients. Next slide, please. We'll start with an update in cardiac manifestations, and we'll start by talking in the tan box on the left about some of the clinical syndromes that have been recognized in cardiology. There have been a number of case reports of myocarditis, myopericarditis in tamponade, and some of these cases have been fulminant presentations. There's been a lot of discussion about the prevalence of cardiomyopathy, and some of this came out of the Evergreen ICU study. So this was a study of 21 ICU patients at Evergreen Hospital outside of Seattle, and they found that 7 out of 21 of their patients had cardiomyopathy. In the multi-center ICU study out of Seattle, they found actually that 0 of 9 patients had cardiomyopathy. So I think the true incidence of cardiomyopathy in these critically ill patients is not yet totally known. Arrhythmias have been described in anywhere between 6 and 17% of patients, although the exact type of arrhythmias is not always described. Turning to the box on the right, there have been 2 high-profile papers in the last week, one in JAMA and one in JAMA Cardiology, talking about the association of cardiac injury with adverse outcomes. So these are both clinical studies from China. One was 187 patients, the other 416 patients, and they showed that there was cardiac injury in 20 to 28% of patients. And cardiac injury was described, categorized basically by an increase in troponin, irrespective of EKG changes. And they found that cardiac injury was more common if patients had pre-existing cardiac disease. Cardiac injury was associated with an increased risk of complications, and that included arrhythmia, ARDS, intubation, and AKI, as well as increase in inflammatory markers, including white blood cell count, CRP, and D-dimer, as well as an increased risk of death anywhere from 6 to 10-fold. And they postulate that cardiac injury may be due to either direct infection, systemic inflammation, or demand. And I do want to mention that other respiratory viruses, including influenza, have been also shown to have an increased risk of MI, and that is thought to be due to systemic inflammation. Next slide, please. I want to take a moment to talk about ACE inhibitors and angiotensin receptor blockers. There's been a lot of attention paid to these drugs because the ACE2 receptor is the SARS-CoV-2 cell entry receptor. And it is unclear at the moment if these drugs would actually worsen COVID disease or improve COVID disease. And both have been hypothesized. And the idea is that these drugs could worsen COVID potentially by increasing ACE2 receptors for the actual virus to gain cell entry, or on the other hand, they might improve COVID disease by decreasing pulmonary inflammation. And there's some animal model data from SARS-CoV-1 that might support that. But because of this unclear effect in COVID and because of the likely harm in stopping these drugs in patients who need them, multiple European and American specialty societies have advocated that patients who are already taking these medicines should continue them. And just to note that there are clinical trials underway of both a recombinant ACE2 molecule as well as losartan. Next slide, please. So let's turn to an update in GI manifestations. So as we talked about in the last grand rounds, GI symptoms, diarrhea, nausea, vomiting are relatively uncommon. So about 1 to 10% of patients in most of the large clinical case series to date. There have been 2 other case series of 69 and 452 patients that did report a higher rate of diarrhea between 14 and 27%. So this may be a bit more of a common symptom. But importantly, what I wanted to talk about today was that there have been reports of atypical cases where patients have GI symptoms without other respiratory symptoms. And this was reported in 2 case series in the GI literature of 204 and over 1,000 patients, where they found this in 3 and 10% of those patients. So that's just important to look out for and to consider testing in those types of patients. Next slide, please. There's been a lot of attention in the media with regards to the loss of smell as a potential clue to COVID. And most of what's out there are media reports and some statements from some ENT societies. There is one published paper on this that was published last week in Clinical Infectious Diseases. It was a cross-sectional study of 59 hospitalized COVID patients in Italy. And they found that these patients had an olfactory and/or taste disorder in 20 patients, or 34%. There was an isolated taste disorder in 10%, and dysgeusia was more common than ageusia. An olfactory disorder alone in 5%, and those patients had hyposmia in all cases. And then a mixed taste and olfactory disorder in 19%, and many of those patients did have anosmia, or the loss of smell. They found that these disorders were more common in women and younger patients, interestingly, and that all patients at the time of the survey had persistent symptoms, and the survey was done on day 15 of symptoms. Anecdotally, we have heard reports of people having improvement in these symptoms over time. The mechanism is not entirely clear. It might be due to direct infection. We do know that SARS-CoV-1 can infect the olfactory bulb versus an inflammatory effect. We know that there are ACE2 receptors throughout the nasal and oral cavity. Next slide, please. The last clinical update I wanted to give is with respect to ocular manifestations. So this was a paper that was published 2 days ago in JAMA Ophthalmology, looking at ocular findings in patients with COVID. This was a study out of China where they looked at 38 patients and found that 12 of them, or 32%, had ocular manifestations, all of which were types of conjunctivitis. They found chemosis, conjunctival hyperemia, and epiphora, which is watery eyes for those not as well versed in the ophtho literature. And interestingly, these were found mostly in patients with moderate, severe, or critical illness. So it seemed that the sicker patients had ocular involvement. And interestingly, one patient had epiphora as the first symptom of COVID disease. They looked in all patients to see if they had a positive conjunctival swab, and only 2 of 11 had a positive RT-PCR for SARS-CoV-2. So one of the accompanying editorials to this article pointed out that potentially the main point here is that from an epidemiologic standpoint, that there potentially could be transmission through the eyes. Next slide, please. I want to talk a little bit about COVID in patients with cancer. There have been 2 papers in the last week discussing this. So the first is a paper on the left from JAMA Oncology, where they looked at over 1,500 patients admitted to a cancer hospital in Wuhan. And they found that 12 patients had COVID, which was an incident rate of 0.79%, which was twice the community incidence at the time. 58% of the patients had non-small cell lung cancer, and 42% were on active chemo or XRT, and they had a 25% mortality rate. The other study was in Annals of Oncology, where they looked at clinical features of 28 cancer patients with COVID. Again, lung cancer was the most common in this series as well. About a third of patients had stage 4 cancer. 21% had chemo or XRT within 14 days, and those patients, potentially not surprisingly, had a higher risk of severe disease. In this study, 29% of patients actually acquired COVID while they were hospitalized for another reason, and they found a 29% mortality. So I think the 2 features that stand out to me from both of these cases are the high prominence of lung cancer in both of these studies, and then the high mortality rate, although these are small studies. Next slide, please. At the last Grand Rounds, we talked about the co-infection data, which at that time had mostly come out of China and Singapore, and they had reported mostly a 0 to 6% co-infection rate, although it was not clear at the time how systematic the testing was. There are now a number of studies in the US that report some co-infection data. The first is a study out of LA and USC, where they looked at 7 COVID patients who were all tested for flu and RSV, and 0% were positive. The Evergreen ICU study out of Seattle, of 21 patients, reported 1 patient with Pseudomonas bacteremia, and then 3 out of 21, or 14%, did have a viral co-infection, 2 with influenza A and 1 with parainfluenza. The multi-center ICU study out of Seattle had systematic testing. They had 0 patients out of 23 with a viral co-infection, and 0 out of 15 with a positive sputum culture, and 0 out of 20 with positive blood cultures. So out of those 3 studies, the co-infection rate ranged from 0 to 14%. I will mention the Stanford data because this is commonly cited, and just to mention that this is reported online only, not in a peer-reviewed manner. But they found that 11 out of 49 of their COVID positive patients, or 22%, were positive for another respiratory virus, although none with influenza. So I think the true co-infection rate is still not entirely clear. There haven't been any very large systematic studies to date, but probably the true rate lies somewhere within this range. Next slide, please. So we'll wrap up with talking a little bit about the clinical course in the ICU, and we'll start by considering some of the critically ill patients in terms of their mortality rates. So in China, there have been about 3 studies of critically ill patients with a 61 to 78% mortality, and then a very high mortality rate, 81 to 100% in intubated patients. In some studies of ICU patients from the US and the UK, the rates have been a little bit lower. So in the Evergreen ICU study, 21 patients in the ICU, 71% were intubated, and they had a 67% mortality. In the multi-center ICU study from Seattle, 24 patients, 75% were intubated, and they had a 50% mortality, including 50% if they were intubated. So that was a bit better than the Chinese data, and their ICU length of stay was 9 days. And then there's an ICU report out of the UK of 196 patients, again, 75% intubated, so that's pretty consistent, with a 48% mortality, and their ICU length of stay was a bit shorter. So again, pretty high mortality rates out of the ICU, although in the US and UK seems to be a little bit lower than the data from China. And I'll wrap up with the question of cytokine storm. So there have been a lot of anecdotal clinical observations about the question of cytokine storm in some of our critically ill patients. A lot of this has been driven by several reports in the literature that severe disease and death seem to be associated with higher inflammatory markers, including white count, CRP, D-dimer, ferritin, IL-6, and TNF-alpha. It's not totally clear, though, what the pathogenic role is of these cytokines, and there's a lot of interest in whether we should be targeting these molecules as a therapeutic strategy. And I think we're going to learn a lot more in the coming weeks about both the pathophysiology and potential targets for therapy. And I'll wrap up there. Thank you so much for your attention.
Thank you, Jen. That was terrific, and actually a perfect bridge to our last of formal talk, which is by Luetkemeyer, who's a professor in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital, where she directs the HIV Clinical Trials Group, which conducts both investigator-initiated and industry HIV trials, and she is helping to lead our therapeutic trials enterprise for COVID here at UCSF. So, Annie.
Thank you. Thanks so much. I'm really happy to give an update on COVID-19 treatment. As we talked about several weeks ago, I think it's most helpful to divide this up into two buckets. So in my introductory slide here, I've included on the left-hand side a schematic of a typical coronavirus life cycle, which is where we typically think of antivirals being effective. And we want to have effective antivirals to help stem the tide of the disease. And then on the right-hand side, this is just a CT scan from a typical patient with sort of the pathognomonic findings of COVID disease with a really robust inflammatory response that we see not only in the lungs, but as Jen referred to, really throughout the body and affecting other organs. So this has led to a lot of interest in targeting this robust immune response with immune modulators. These two approaches are occurring very quickly in the research, and I'm going to highlight some of the updates today. Next slide. So remdesivir is a drug that we talked about several weeks ago that's gotten a lot of attention. This is a nucleoside analog, just as a reminder, and it inhibits RNA-dependent RNA polymerase. And so in the schematic here, I've highlighted where in the life cycle this is active. In vitro, remdesivir looks like it has some broad antiviral activity against a number of coronaviruses and other viruses, and it's given only as an IV medication. So what do we know now about remdesivir and how it works? Well, I would caution us, first of all, that there are a number of clinical case series that have been published that will include a handful of patients treated with remdesivir through compassionate use. And I think we can't draw any conclusions about those patients at this point in time and how effective remdesivir may have been because they were not controlled. But the good news is that we have 5 large randomized controlled trials that are underway. And we anticipate the first results probably from the randomized controlled trials conducted in China to be coming out very, very soon. These are actively enrolling. One of the studies is actively enrolling at UCSF and San Francisco General, and a number of the other studies are actively enrolling around San Francisco and across the United States. One other update about remdesivir is about the compassionate use program. I think many had accessed remdesivir through this route, and as you may have seen in the news, this has been closed with the transition to an expanded access or EAP program that's starting. Just as a reminder, though, that this is a limited access that really is for people who are intubated, so quite ill, but not on pressors and don't have multi-organ failure. But I think many medical centers, including our own, have moved towards getting expanded access remdesivir, but it is not available to many, including at UCSF yet, but we're actively pursuing this. So I think the take home for remdesivir, one of our exciting antivirals, is stay tuned, we need more data. Next slide. So hydroxychloroquine, boy, who thought we would ever talk quite so much about hydroxychloroquine? And I think it's become increasingly confusing to understand what hydroxychloroquine is actually doing. Hydroxychloroquine falls into the category of both an antiviral and an anti-inflammatory. And what are the updates that I have to share for you? Well, there have been 2 randomized controlled trials that were reported out of China, both of which were conducted in mild disease. And I'll just remind you as a caveat, as Chaz nicely referred to, that in patients with mild to moderate disease, as was summarized in the Wolfel paper out of Germany, most patients get better, and most patients have a steady decline of their detectable viral load by culture and by PCR. So we really have to be careful when drugs are given and then they report that the viral load comes down and that patients get better, because that's what we expect to see with the majority of patients who are not critically ill. So in this first randomized controlled trial in the left-hand panel, it was 30 patients. They got hydroxychloroquine 400 milligrams a day compared to standard therapy. There's another caveat here that standard therapy in this study could be a wide variety of antivirals, and many individuals received more than one treatment, including inhaled medications and oral medications. It was open label. 80% of the patients had mild disease, and the primary endpoint was day 7 PCR. 13 out of 15 of those on hydroxychloroquine had an undetectable SARS-CoV-2 PCR, so 87%, and 14 out of 15 had an undetectable PCR, or 93% in the control arm. There was no difference in clinical outcomes or safety. The second randomized controlled trial was slightly bigger. 62 patients also got 400 milligrams daily of hydroxychloroquine versus, again, standard therapy, which could include a whole variety of antivirals, and those were not controlled. It was unclear to me, at least, whether or not this was a blinded study. This study pre-specified that it was only for those with mild illness. The primary endpoint was the clinical status at day 6, and there was no virologic data reported yet from this group. What they found is that there looked like there was a trend towards a 1-day reduction in fever and cough in those who were treated with hydroxychloroquine. 4 individuals progressed on to severe illness in the control arm, and 2 individuals had a drug interaction in the hydroxychloroquine, a drug reaction in the hydroxychloroquine arm, but it was not a QTc prolongation. So what can we conclude from these 2 studies? I don't think we can say much, given that these also really mirror what the typical natural history would look like in terms of clinical recovery and virologic decline. So it's reassuring to see limited safety signal here, but I think we need more data. Another important point is, what's the right dose of hydroxychloroquine? These are data from Rita Savik and colleagues here at UCSF that have modeled the available data on hydroxychloroquine and its efficacy in SARS-CoV-2. And these data suggest that dosing at 400 milligrams a day is going to be really too low to get you above the extrapolated patient EC50 that the target is, that we likely want to target. And that really higher doses like 600 milligrams twice a day may be what we need to get us above that EC50, but keep us below concerning levels for QTc prolongation. Next slide. What about hydroxychloroquine and azithromycin? There were some intriguing data out of a group from France that suggested that hydroxychloroquine given with azithromycin reduced the viral loads more quickly than those who did not receive that combination. In a follow-up study from the same group, a single-armed, uncontrolled study of 80 individuals, mostly with mild disease, received hydroxychloroquine 600 milligrams a day and azithromycin. And what this graph shows is that there was the black bars are those who had virologic testing, the brown bars are those who were undetectable at those time points, and you could see there was a trend towards the viral load coming down. I didn't show the data, but the culture also, there was a trend towards that becoming negative. Most of these patients did well. 3 were transferred to the ICU, 1 stopped, and 65 had been discharged out of the 80 at the time of this publication in preprint. What can we say about this? I think we can say that these are people who, in general, will be expected to do well. This is what we expect to see with the viral load coming down. So it's really difficult to say how much of a role hydroxychloroquine with azithromycin is having here. There was a contradictory study then to this in contradistinction from the French, different French group. There was a small study, single arm, uncontrolled, 11 patients, same regimen of hydroxychloroquine and azithromycin, and they found slightly worse outcomes. 1 patient died, 2 had an ICU transfer, 4 had QTc prolongation, but only 1 had to stop drugs because of it. Excluding the person who died, they found that most patients were still PCR positive at day 5 or 6, and their conclusion was there was no evidence for rapid viral clearance or clinical benefit. So where do things stand right now with hydroxychloroquine? We still don't know if it has efficacy in people living with COVID. The dose may need to be higher. I don't think we know if there's any role of additive azithromycin, and to really sort this out, we're going to need robust clinical trial data. And I think that we need to be careful about the safety of hydroxychloroquine with unmonitored use. We've seen, reports of people overdosing when taking this outside of the medical setting, and certainly concerns about the impact on the drug supply. Next slide. What about convalescent plasma? This is also an antiviral strategy. It's been around for a very long time. It's one of our oldest medical interventions. You can see this, this picture from 1918. We have data for reduction in mortality from the 1918 flu, as well as more recent H1N1 outbreaks. Convalescent plasma was used in SARS and MERS, and the suggestion is that earlier treatment was more efficacious, but there are anecdotal data to support use in critically ill patients. In COVID-19 patients, I think we were all heartened to see this JAMA publication showing that 5 patients who were critically ill did well when they were treated with convalescent plasma. We know from the data that Jen just showed us that in general, when people go to the ICU and are intubated, they can have poor outcomes, but I think we need more data. We now have an FDA emergency IND for severe or life-threatening disease, which I think will help us get access to patients who may need this, but we're really going to need to understand who is best served here. The other area where convalescent plasma really may be quite useful and is being explored is to provide post-exposure prophylaxis for individuals who are at high risk and in healthcare workers who may be at high risk as well. One really important point is we're all starting to see these patients and that as they get well and leave the hospital or leave our care, encourage them to give blood. Many blood centers are getting their SOPs up and going to allow people to donate blood so that they can provide convalescent plasma. And this is a really important way that they can help in the efforts to understand how to treat SARS-CoV-2 better. Next slide, please. So what about immune modulation? This is the other bucket that I referred to, and this schematic on the left-hand side shows what happens to people with moderate disease. As Jen referred to, we know that the TNF-alpha levels, IL-6 and IL-10 go up, and that there's some immune dysregulation there. And when people progress to severe COVID-19, we can see what's been called a cytokine storm. And a number of different inflammatory markers are elevated in this setting, which are summarized below. This has led to a lot of interest in using the immune modulators on the right-hand side of the slide. These include IL-6 inhibitors, IL-1B inhibition with canakinumab or colchicine, which can affect the inflammasome, JAK-STAT inhibitors, which also have broadly anti-inflammatory activity, even CCR5 antagonism or GM-CSF inhibition, as well as the great anti-inflammatory steroids, for which I think the jury is still out. I think the considerations for these wide variety of anti-inflammatories is that we need to understand, is it worth targeting one single pathway? Is that going to be the highest yield approach? Or do we really need a combination approach, not only with antivirals, but also with other anti-inflammatories? What is the optimal timing? Is this should best reserved for people once they become critically ill, or were we better served by trying to avoid them becoming critically ill? And then lastly, might we hurt people by doing this? We may be immunosuppressing them more and contributing to disease exacerbation in already quite critically ill patients. So we really need to understand that piece. And again, study these medications very carefully so we know if we're hurting or helping by using these strategies. Next slide. What about the vaccine? This is a brave individual, Jennifer Havlir, who was the first person to receive a COVID-19 vaccine. Questions about coronavirus immunity. We know that immunity to cold-causing coronaviruses is limited, but we also know that those are mostly upper airway diseases. When we see lower respiratory tract diseases like SARS and MERS, these are associated with more durable immune responses, which suggests that coronavirus 19 may also elicit a more durable immune response. There are a number of major approaches that are ongoing. The WHO has a really nice vaccine landscape website that is being updated, and the platforms that are being studied are summarized here. There are more than 47 candidates and counting. These seem to go up every day when I look here. Excitingly, we already have 2 in human safety trials. The Moderna vaccine, which we see in this picture here, which is an mRNA subunit vaccine, and then CanSino, which is looking at an adenovirus vector. I think the unfortunate piece here is that it's really difficult to rush vaccine therapy. I think people have really rushed to get these compounds into studies, but we anticipate that it will be at least 12 months until widely available. Will be a very welcome tool when we do have them. Next slide. So I want to just end here by highlighting the current clinical trials that are available at a variety of the UCSF campuses. This is evolving on a daily basis, which is really terrific. It means that we continue to have interventions that we're offering to our patients, both on the hospitalized side and then increasingly as possibilities on the outpatient side. I am co-chairing a committee along with other ID, pulmonary, and critical care researchers looking at interventional studies for treatment and prevention. And my contact information and Michael Mathay's are below, and we welcome people reaching out if they have other strategies that they want to talk about, so that these can be discussed and prioritized, so that we're ensuring that we have a good flow of research opportunities and therapeutic interventions for our patients. So I'll go ahead and stop there and just leave this as a reference for people down the road if they're looking for studies.
Thank you, Annie. My computer's making a strange noise, so I will try to address it. Let me bring back all of the speakers from this session before we move on to panel. We'll do about 10 or 12 minutes of Q&A. That is an odd sound. Cannot figure out what that is. Okay, so let's start with Diane. Should the general public start wearing masks?
Okay,
You're on
good.
mute. There you go.
My own opinion on this is yes, it makes sense. We have no vaccine, we have no treatment for this disease, and it does offer, it makes sense from what we know about transmission. It's certainly, homemade masks are of no value in the hospital, but if we can do anything to spread, I think it is a good idea to do. And I think right now it could make a difference when we think about when and how that we are going to be able to back out of the current state that we're in.
Okay, thank you. I think I figured out my problem. Next question for you, Diane. You sort of hinted at, and maybe George will get into this too, but the breakout idea. So how do we know that we have reached that stage? Do different regions reach that stage at different times? And just paint a, let's assume that here in California, we reach that stage in 6 weeks. So what does life look like in San Francisco 8 to 10 weeks from now?
Well, I think, everybody probably has a different opinion about this, but when you just think about first of all, we need the data to be able to make that assessment. Like we need to know, we need testing, we need lots of testing. So we know how many infections are we having right now, because once we get to that stage, as infections start coming up, we're gonna have to contact trace them, right? So if there's a ton of infections happening, that's just not viable. So when we get to that phase, we need to have manpower in place through our health department or other mechanisms so that we can contact trace all the new infections so the ember doesn't spark a new fire again. I think that that's the first thing. Secondly, just in terms of movement and movement restrictions, the package that we know that's been used is that you loosen movement restrictions gradually, and that has occurred in conjunction with the masks. I think one of the unknowns is how can we effectively use antibody testing? How can and should we, what are the performance of the antibody testings, and how can they help us do that more effectively? I also think that we can't be naive. Like one of the hard things about this particular disease, as you heard, is that people asymptomatic can probably transmit the disease. So that makes it a little bit more difficult. And not only does this disease spread fast, but we don't live in a vacuum. We have the Bay Area, we have the whole country, we're built on travel, so we're really going to need to think about those things. We know from public health interventions, and we talked about this 2 weeks ago, if you lift the restrictions too fast, you're going to fail. But I hope over the coming weeks, as we get more data, we're going to have a better sense of when that will be, and I think it's going to be gradual introduction of movement with masks and very aggressive contact tracing and antibody measurement.
And maybe this is both for you and Chaz. When we talk about sort of aggressive testing as we move to that stage, is it viral testing or is it antibody testing? What do we actually need to understand the dynamics if we do reach a stage that the new case rate has gone down to a much lower level? Do you want to start with that, Diane, and then Chaz can chime in?
Sure. We absolutely need testing, and we need, if we could, better tests completely accessible to the public. People need to be able to go to get tested if they think they're ill, and we need specific tests. I think antibody testing would be extraordinarily helpful in terms of many things we can do to make predictions, including modeling, because it tells us the prevalence of the disease and tells us about epidemic dynamics.
Great. Okay, Chaz, why don't you weigh in on that one? You know, we sort of talk about testing, and I think people think about it, okay, there's testing and it used to take a day and now maybe it'll take an hour, and that's terrific. But sort of this layering of testing for virus versus testing for antibodies, how do you think about the balance of those, particularly as we move on to another stage?
Yeah, I think both have a role, without doubt. So testing for viral nucleic acid is unquestionably key for patients with acute symptoms. Patients early during their disease course, viral nucleic acid testing is going to be the test of choice. I think antibody testing is really going to have a role, as Diane mentioned, in understanding prevalence in the population, accurately estimating mortality, and in understanding who might be immune and who might not be immune, something that nucleic acid testing simply can't do. So I think moving forward, both are going to be useful.
Okay, who might be immune? If I have antibodies, am I immune, and for how long?
So this is a very good question, and one that is still unanswered. You know, there was a compelling paper looking at rhesus macaques demonstrating they could not be reinfected. However, there are other data, some anecdotal, some more robust, suggesting that patients may be able to be reinfected. So I think globally, there is probably some degree of immunity that happens. It might be completely protective, but I think that those details are still not fully worked out. So an area that definitely needs more research.
Okay, and there was a number of questions about this issue of asymptomatic patients and the sensitivity, which is neither of those are very reassuring. I mean, I think where we were several weeks ago, the party line seemed to be more, there's not much of an asymptomatic phase, that most people will have symptoms of some sort. And that sounds like from the cruise ship, we now understand that there actually is a fairly significant asymptomatic phase, and the test can be falsely negative in those folks, and maybe even some people with symptoms. So how do we get our heads around this, and how does this new knowledge shape what we do going forward?
Yeah, this is an important question and an important area that also needs to be further explored. You know, I think several studies now demonstrating that viral load in various locations in the human body is highest early during disease onset, maybe provides the most significant indication of how important transmission might be early during the course of infection. You know, I think these data do play into our understanding of what might be needed to effectively protect people.
Yeah, but maybe take us a layer deeper than that. So how, you know, a couple of weeks ago, we were kind of walking around and saying, you know, if you didn't have any symptoms at all, you were safe, and being in contact with you was safe. And now I guess I don't feel that based on the emerging data. Is that your feeling as well? Have you changed in your assessment of this? And then what is the implications? Does that mean, is that the reason we should all be wearing masks? Is that the reasons that we should or shouldn't be concerned if we go out to the store?
Well, I think it's a complex situation, and there are a lot of moving parts. So we know with very good data that this coronavirus is transmitted by droplet particles and by contact with particles on surfaces. What we do know is that someone without symptoms is going to be less likely to be producing these droplet particles and emitting them in the environment. So while someone without symptoms might have very high levels of virus in their nares, in their oropharynx, they are probably less likely to actually deposit that virus into the environment. I think we're still in a incomplete data situation in terms of we don't actually know the relative infectivity of people during these different stages. But I think the global understanding has shifted from where we were not too long ago, in that patients without symptoms likely could be infectious at a level that we previously didn't appreciate.
I think, Bob,
Thank you. Yeah, go ahead, Dan.
one other thing, I think that is a strong rationale for wearing masks. And I also think, like when we saw the choir outbreak, you know, when you're singing, you're doing forced air. And I think that there are situations where we've got more data now. We know the virus is there, and it might not be, you know, a day before, but still it's transmissible. So, I mean, compared to SARS, where that doesn't happen until 5 or 6 days into the illness, this is one of the most difficult things with this virus right now.
Okay, thank you. Jen, maybe you could unmute. Issues around convalescence and when you know you're better, and are you infectious? Someone asked for outpatients with diagnosed COVID-19, but who have not been tested, how long should they stay in isolation? There's a bunch of different questions, but a lot of it relates to sort of the end game of this isolation. Patient in the hospital who's getting better, when can they leave? When could they go to a skilled nursing facility? All of those kinds of questions.
Yeah, I mean, I think we do know from the data out there that even when people no longer have symptoms, they may still test positive. And Chaz showed some really nice data that the PCR positivity may not correlate with culture positivity. So what you may be finding is dead virus. But what we don't know is, as Chaz mentioned, how we don't know how infectious asymptomatic people are. We also don't know how infectious people are at the end of their course. Our discharge criteria currently are based, or at least in terms of isolation and return to work, are based on symptoms rather than testing, at least for our immunocompetent patients.
And, you know, we all get calls all the time from friends and family. I had what I think was COVID, but didn't get tested. First of all, how likely is it that they had it? And second of all, how long should they stay in strict isolation if they didn't get tested?
Yeah, I mean, I think it depends on the situation, right, in terms of how likely they are to have it. I think if someone had a contact, then that's going to increase their likelihood that it was COVID rather than another respiratory disease. Remember, we're still in flu season. We're still seeing a lot of circulating winter viruses. So a lot of people who are being tested do not have COVID. I think our testing positivity rate at UCSF right now is around the 4 to 5% mark. So we're testing a lot of people, and we're only finding positives in 4 to 5%. Now that's we're testing very broadly, which is appropriate.
But I guess it should be said, we're only testing people with symptoms. So even testing people with only with symptoms, 1 out of 20 is positive.
Right.
Yeah.
We're expanding, and Sarah can certainly speak to this more in the next session, but we've expanded our testing a bit to asymptomatic patients in certain circumstances.
Okay, maybe thanks so much, Annie. You had a slide at the end of last time that sort of was the guidance about what to do in various subgroups if you don't have clinical trials available. So, real doctors have to make real decisions with real patients today. So can you take us through what and I recognize that pretty much everything you said was we don't know the right answer to any of these things, but still people have to make decisions. So what is your treatment recommendations today for someone with mild symptoms, someone with symptoms enough to be in the hospital, but not so bad, and then someone who's sick enough to be in the ICU?
Yeah, and I'm assuming that clinical trials aren't an option, so I'm going to answer.
Clinical trials are not an option.
Clinical trials are not an option. So I'll start with the easier part, which is if people have mild symptoms, I think that in general, it doesn't make sense to treat them outside of a study. There are a lot of studies going on. We need to understand if we can sort of break disease transmission, but most people with mild symptoms will do very, very well. And we don't have to worry about it. They need to worry about not infecting others and come in if they're one of the few who gets more ill. If that is a person with a lot of comorbidities, they're older, they have diabetes, hypertension, and you're very concerned there could be a consideration for using something like hydroxychloroquine, but I think the real caveat with that is that it needs to be in conjunction with a medical provider who could make sure that they don't have worrisome drug-drug interactions, they don't have a pre-existing QTC prolongation, and that we're not hurting them. Because we have to recognize that we don't know if this medicine works, and so we have to make decisions in the do no harm rubric there. Once people come into the hospital, and we have a lot of people who are in our hospital where they're not intubated, but they're on oxygen, and we don't really know, we're only offering them supportive care. I think you're still in the same discussion about whether or not an intervention like hydroxychloroquine makes sense. And I think that it should be considered on a case-by-case basis. Once you've really looked at what the potential downsides would be, then I think it's reasonable to offer, again, fully recognizing and having a discussion with the patient that we don't know if this works. Once people become critically ill, I think it becomes very challenging, and we don't have a lot we don't have anything to offer that's targeted to COVID-19. But this is the case where I think it's useful for medical systems to try to prepare with things like emergency INDs, to have access to convalescent plasma. That may feel like a Hail Mary, and it may be a Hail Mary, and in many cases that's just not going to be possible if there's a super high volume. But I think that there are cases in the literature where it looks like it may have been effective. Having EAP access to things like remdesivir, I think that those will be helpful. And then just going back to the basics of making sure that you're providing the best possible ARDS care, because that's a very complex series of interventions, much of which is data-driven. So that is what, at the end of the day, is what people become very ill from. So we need to provide very good ARDS care to those patients.
Great. I'm going to let all of you go and bring on our next group of virtual applause from our 1,500 people watching. And thank you so much. And let's bring on the next group. We'll extend the conversation to a different set of experts and cover a few other areas that we haven't touched on quite as much. So our next group is Matt Aldrich, who's professor in our Department of Anesthesia and medical director of critical care, who's really been directing our ICU response. Brad Monash, associate professor of medicine and pediatrics here, and associate division chief in hospital medicine, who's been helping direct our response from hospital medicine. Sarah Doernberg, who's associate professor of infectious diseases, runs adult antimicrobial stewardship, and has been helping to direct our ID and infection control efforts. George Rutherford, who's a professor in our Department of Epi and Biostatistics, and his research focuses on epidemiology and prevention and modeling of infectious diseases, which is something we're all very interested in. And Sirisha Narayana is assistant professor in hospital medicine and is chair of our ethics committee and chief of the ethics consultation service, and is helping to lead our work in trying to think through some of the key ethical conundrums. So let me start with maybe a combination of Matt and Brad and ask the question of sort of what you're seeing clinically, and do either of you have a sense of which patients who are hospitalized but are doing okay are likely to start doing poorly? All the reports seem to be that patients can look sort of okay and an hour later look really bad. So first of all, is that what you're seeing? And second of all, do you have any clues who those people are, both from the standpoint of the patient on the ward, from Brad's standpoint, and from Matt's standpoint, receiving them in the ICU? Brad, you want to start?
Yeah, sure. I'll start with that. I think we have a team at UCSF that's currently looking into this to try to identify predictive factors for patients who are not going to do well. I think it's been recognized in the lay press as well as in scientific literature that there are patients who seem to do very well for that first week of illness and then rapidly deteriorate in the second week of illness. Some of the data I've seen is suggestive that the presence of dyspnea and respiratory distress early on portends a worse prognosis for a certain subset of patients. But beyond that, we don't have great predictive analytics yet, but I anticipate in the not so distant future, we'll be able to do a better job predicting which patients will deteriorate. We've been handing some of these patients over to our ICU colleagues, so I'm interested if Matt has additional input here.
Yeah, actually, before you go, I'd be interested in that, because one of the things that we have seen, and I've been asked a lot about this, is sort of this flipped ratio early on. The ratio of the patients on the ward was much higher than those in the ICU. That has flipped. And I was wondering whether some of that is because we're not getting crushed just yet and we have some ICU capacity. Is your threshold, this is actually for both of you, is your threshold to send a kind of marginal patient to the unit lower than it would be in a place where the units were very busy with sicker patients?
So currently the answer is yes. We have developed some expertise outside of the ICU for the management of this patient population. We have developed a respiratory isolation unit patterned off of pandemic wards in Singapore, where we have just local interprofessional expertise in managing this population. Not to say we can't manage these patients very well outside of this unit, but based on this sort of culture we've developed in the unit and the concern for rapid deterioration of patients who are not appropriately monitored, at this point, as we are building our capacity outside of the ICU, we are maintaining a low threshold for patients with coronavirus who have respiratory distress or respiratory symptomatology, who are having escalating oxygen requirements. Right now, we're maintaining a very low threshold to manage those patients in the intensive care unit.
Yeah, one last question for you, then I'll hand it to Matt. When I see the report every day of we have X number of patients on the ward who actually have tested positive for virus, and then there's that clicking in again, I'm sorry. And then we have a number of other patients who are under investigation. First of all, what percentage of those are turning out to be positive? And second of all, do you then move them off the ward when they turn out negative?
So right now, the last numbers I heard was about a 4% positivity rate of our testing. That about 4% of patients we are testing are coronavirus positive. And our plan right now is to move whatever patients we can who are sort of acute care level to this respiratory isolation unit. And so we are developing protocols with our nursing colleagues to manage patients who perhaps historically they have not been managing, including potentially bringing nurses into that unit with expertise if needed. And as well as developing the expertise in the ICU, which is existent there to manage patients of PCU or ICU level care. So we have been fortunate locally on a population level, not to belittle the terrible realities of our patients who have been affected by this disease, but on a population level, as people have heard, we have been incredibly fortunate locally, and perhaps related to our early physical distancing measures, that we are not overwhelmed. Our volumes are very manageable, and while we have the capacity, we are intending to cohort patients as much as possible into our acute care respiratory isolation unit and into our ICUs.
Okay, so Matt, let's turn to you and just tell us a little about what you're seeing and kind of the decision making about who goes into the ICU, and also I'd love your thoughts on this sort of flipped ratio. Why is it that the ratio now is so ICU heavy compared to the rest of the hospital?
Well, I think part of it is just, it has to do with the volume of patients that are coming into the hospital, and I agree with Brad. We have had a lower threshold in terms of who we will bring into the ICU. So we've mainly been using an acute care ICU approach as opposed to a TCU approach, and we have that because of our capacity. We're able to do that now. What we're seeing in the ICU, and we've had 12 total patients now who have required critical care at some point, so we have some experience, although I'm very cautious to interpret too much from this. I will say I think there's a lot of well-intentioned desire to gain experience from what other institutions have gone through over the last several weeks. I think we all need to be cautious about what we see in anecdotal reports and rely on what is now a growing literature of peer-reviewed studies. So what we're seeing is more consistent, I would say, with what I have seen reported in the literature from China, from Italy, and now we have two small studies, one from the Seattle area hospitals and the other one directly from Kirkland, from Evergreen Hospital. We're seeing largely what's being described in the literature, and perhaps less so than what I think many of us have seen in email threads and anecdotal reports. So, and by that I mean we are seeing, generally speaking, our patients are in fact older, or they have significant comorbidities. We are not seeing a significant number of young, otherwise healthy patients. And we are seeing patients with long ICU length of stay, which is consistent with what Jen Babik described. Certainly for patients who progress to ARDS, the course is long and they require lengthy mechanical ventilation. And that's, you know, we're still relatively, we're not early in our process as an institution. I mean, we've been taking care of patients for many weeks now, although I think certainly this increased volume, not a markedly increased volume, but this increased volume that we've seen has given us more experience over the last few weeks. So I think we really are seeing something that's consistent with what's been reported in the literature.
And when you read the literature now with some variations of whether the mortality rate is 50% for a patient who's been intubated or 80 or 90, and it seems like literature isn't quite sure what the right answer is. I imagine we'll get to Sirisha in a little bit, but that matters in terms of decision making, particularly if it turns out the ventilators are scarce. Clearly we haven't seen enough patients to know for sure here, but as you read the literature, do you have a feeling about that?
Well, we're certainly aware of the literature, and we're aware of the literature of what's reported in terms of outcomes for patients who require ICU level care, and then even the other subset of patients who require mechanical ventilation. I think it's too early for us to tell. I think, as I said, I mean, it is a long course, and so I think our main approach now is just recognizing that and set expectations for ourselves, for the staff we work with, for families, that certainly once we get to the point of respiratory failure requiring mechanical ventilation, we are not expecting rapid recovery. We're expecting patients who may require 1, 2, 3 weeks or more of support with mechanical ventilation. So we're still hopeful that we can continue, that we can improve outcomes, and that we can provide the kind of evidence-based critical care that we've done for years. And that's going to be our approach going forward.
Have we seen anyone come off a ventilator who's been intubated for ARDS?
We have, but I still think, I mean, perhaps we've only seen one at this point, just because of the time course of where we are with our somewhat higher volume of ICU patients.
Mm-hmm. Okay. Sirisha, maybe I'll turn to you, and it's sort of a natural segue as we talk about intubated and ventilated patients and what their outcomes are. Don't spend too much time going through the process. I know we're going through all sorts of reading what others have done and seeing there are algorithms out there and all sorts of white papers. Just practically, how are you and your colleagues approaching this matter of preparing for a day, which we hope we will never see here, but they are seeing in New York, where you have to make decisions about 2 patients that need a ventilator and we only have 1?
Thanks, Bob. Definitely something that is key on everyone's mind, given what we're seeing in New York. So I think one thing that can guide us in thinking about the process and how we would make this decision is a general public health ethics mantra, which is the idea of creating the greatest medical benefit for the greatest number of patients. And it's a little different from how we might think about our individual role when it comes to a unique patient that we're caring for, because we're looking at the population as a whole. That said, even when thinking about the greatest good for the greatest number of people, we're also trying to balance the intrinsic worth of each person and the moral equality of all people, and really trying to identify, in the situation of a scarce resource, we can take ventilators as an example, who is going to actually benefit from that resource the most, such that we are actually promoting the greatest health for the population as a whole. So if we take that into consideration, or we take that as our foundation, then the next steps are really trying to say, how can we be as objective about this as possible? And that's where we get into scores, and if those of you who've read protocols or seen the press, there are various ways that you might try to make predictions about who might benefit the most from these scarce resources. So there are some scores out there, SOFA scores, frailty scores, and then it's the context of, well, how critically ill is this patient? How, as Matt was alluding to, a lot of our patients in the unit do have other comorbidities. How likely is it that investing in a ventilator for that particular patient going to actually help them survive until discharge, which is honestly probably, while in the grand scheme of things is a very short-term marker, for the purposes of triage, maybe our most effective marker to make sure there's equity and objectivity in what we think about.
Is survival until discharge the main issue, or is it also then expected years if you make it to discharge? And if so, how do we be sure we're not discriminating against older people?
Yeah, so this is definitely a challenge here. You know, I think the survival until discharge allows for us to really focus on triage and minimizes the tendency to then make broader assessments where we get into difficulty in making assessments on quality of life, for example, or how many more years are left, for example. And that's where I think it helps us try to be as objective as possible. Again, as Matt was alluding to, this is an evolving disease process, and there are a lot of elements that we need to continue incorporating as we learn more about the disease process overall. One of the other challenges in doing this kind of work is really this is quite theoretical, right? We're trying to create documents and create protocols that we can functionally execute at an operations level, but there may be a lot of nuances that we figure out only as we're actually executing them that we then go back and address and iterate on.
And have you been in touch with anybody in New York who is it's no longer theoretical, or maybe it is today, but it might not be tomorrow?
Yeah, and there are, New York State actually created ventilator protocols back in 2015 that's been pretty widely circulated, and I've seen documents out at Sinai. And the situation is sometimes despite having a guideline or a marker, you're having to make very quick decisions in real time when you have 5 to 20 of the same patients coming in at you. And so I think it's still a work in progress to figure out how can we take that burden of responsibility out of the individual bedside clinician and to a larger objective body that can work very quickly as objectively as possible so no one group is discriminated against.
Got it. Well, let me turn to Sarah. And I don't know if you thought you'd be spending as much of your life on PPE as you have, but we went a few days ago to universal masking in the clinical setting. As you heard in the discussion previously, discussion about whether we should have universal masking out in the real world. Where are you on all of that, and how has your thinking evolved in the last couple of weeks?
So I'm a little bit agnostic about the masking in the outside. I am a little concerned that people who put on a mask might feel falsely safe and be tempted to go outside more often than they are currently. So I think we really need to stress that social distancing, capital S, capital D, is the most important thing. Now, I think there are situations where wearing a mask in public may be appropriate. So for instance, if you're going to a grocery store, you need food, and you're going to be in close contact with people, that might be a time where you might consider it. I'm not sure that, if you're going on a walk for some fresh air around the block, that it's going to provide much protection.
Okay. And in the hospital, you and your colleagues were part of a decision several days ago to move from a recommendation not to wear masks in patients that were deemed to be of low risk to one where the decision was made to require masks. All clinicians wear masks all the time. How did that happen? Did we have the availability of masks, or was that because of this emerging understanding about asymptomatic carriers? What went into that?
Yeah, it was a convergence of several different factors. One was the recognition that this is just a really difficult place to socially distance. I think medicine is a social thing. Teams are rounding, we're seeing patients, and keeping a distance is very challenging. So the combination of that recognition, as well as some increased availability of masks in concert with our increasing recognition, though much needs to be figured out still about the asymptomatic spread of that piece of the puzzle.
And as you have come to understand this asymptomatic spread, at least a little bit better than we did when we spoke a couple of weeks ago, how is it changing your overall approach to all the policy issues that you have to weigh in on?
Well, I think it's definitely making me want to test more people. Though there are many caveats to this because we still don't understand the performance characteristics of the test in this asymptomatic population. We're still learning exactly how best to test these people. There's going to be operational issues with test turnaround time and needing to know the answer for some of these tests. But I think the more we can test individuals, both with PCR testing for patients and then eventually getting broad epidemiologic studies of serologic status, the more we'll understand. And so I'm very supportive of doing studies to figure out this issue.
And I think Jen might have mentioned that we have now kind of endorsed asymptomatic testing in 3 different patient populations that sounded like organ transplant, someone who's coming or going to a nursing home, and then patients in whom you can't get a history. Is that a matter of not having enough tests? And if we had unlimited testing, would we expand the number of categories of asymptomatic patients who we would test?
Yeah, this is I think our first foray into starting to test some of these asymptomatic populations. The supply chain, kind of the bottleneck of the supply chain has been test swab availability. And we haven't wanted to expand testing until we're sure we're going to have swabs to test our symptomatic patients coming in reliably week after week. And so we're doing some work to figure out if some of the non-traditional swabs that we do have a more ready supply of would be useful and informative to use for testing.
And if we had them, I noticed that I believe Columbia, New York Presbyterian went to universal testing of hospitalized patients a couple of days ago. If our supply chain was more secure, do you think if we had it today, tomorrow, would we be endorsing broader asymptomatic testing strategies?
It would be very seriously considered. You know, there's the operational pieces that would need to be put in place. For instance, right now, whenever someone new comes into the hospital and gets tested, we're using full PPE for a presumed patient with coronavirus. And so there's concerns about burning PPE as we expand testing that I think need to be figured out, but definitely something that would need to be strongly considered.
Got it, thank you. Let's turn to George. So George, you've become a very popular man in the last couple of weeks because you do modeling. Yeah, right, and epidemiology. And I think, you know, the most common question to you is probably, please tell us when this will end and what the end looks like. So go ahead, it's all yours. Tell us when this will end and what the end looks like.
It depends on what this is. Are you talking about coronavirus as a medical issue? I think it's probably here for the rest of our.
I'm talking about sort of take us to the next phase of, it's gone down some, and then take us to the phase after that. Maybe it's gone down because it's somewhat seasonal and we're worried about it resurging and everybody's sort of forgotten how to be good citizens.
Okay, so you can't forget what you've learned, okay? This is going to, my prediction, at which only Dr. Wachter voices out loud, but my prediction is that we're in a very flat phase. We're looking at something close to the apex right now in terms of bed space and ICU utilization. We'll be out the other end by May, early May, I would guess. Then we'd enter a very long tail with handfuls of cases every day. This is assuming there's no giant outbreak at the Laguna Honda or big long-term care facilities or among the homeless. But we avoid those things. There will be a long tail, which will go well into the summer. There'll be transmission during the summer. When kids come back to school, we'll probably see a bump, and that will, and we're going to have to work on that when that comes out. Meanwhile, we're going to have very aggressive contact tracing in place. We're probably going to have supervised isolation. We're going to have supervised quarantine. We're going to have aggressive case finding. We're going to have a lot more testing, and we're going to be able to corral people who are infectious, I think, better than we are now. If you ask where the resources are, my whole group is being retasked to do contact tracing for San Francisco. That's like 100 people. Okay, so that's the kind of resources you need to do this.
But when you say widespread testing, I'm just struck by the whole asymptomatic thing. I mean, it'd be one thing to say, okay, we're going to now be more aggressive about testing people with mild symptoms, but it sounds like there are people who may have this and who never have symptoms. So is there some random testing that one does, and how do you even think about that?
I mean, the prevalence is way too low to do random testing, I would think. I mean, this is all a function of contact tracing, and we're not just going to do household contact tracing, but we're going to have to do community contact tracing. You know, everybody carries around a cell phone. We can get their cell phones with their permission and find out where they were at 5 o'clock on the Thursday afternoon they were most infectious. And we find out it's the Marina Safeway. Well, that gives us a point of, you know, a point to start looking for people, the people who show up at the Marina Safeway at 5 o'clock on Thursdays, or, you know, or whatever it is. I mean, but these are geographical, these are geographical questions about where people are, you know, are intersecting with potential susceptibles. So we're going to have to learn how we're going to learn by doing. We're in contact with the South Koreans to make sure we understand exactly how they are doing all this. Every app developer in the world has contacted me over the last 3 days with a new app to make this magically go away. And so we're sort of having.
Are any of those promising?
I hear a couple I like, but
Yeah,
you know, there's a lot of sorting to go on to get to that. But the whole, I like the digital thermometer that all the temperatures go up to some place in Corvallis and come back as a nice tidy data set. I like that. But you know, I mean, I can tell you that people in San Francisco have temperatures. Yeah, duh. Okay. But it's like, what block is it in and which house is it? You know, that's the sort of geographical stuff we need, which then starts to make everybody very, very, very nervous.
So let's go to the fall, and we had it went down in the middle of May, and everybody sort of got back to normal. Are we doing widespread antibody testing so we can give people the good housekeeping seal of approval that you're immune? And are we telling a 70-year-old person with a little COPD life, even though everybody else is doing it because you're at super high risk? Are we sort of parsing the population in different ways?
I think we will be parsing the population. I mean, understand that by September, the population prevalence is going to be a few percent.
Right.
You know, unless we have something disastrously goes wrong. But that's the tack we're on. So, you know, this sort of magical cohort effect, we're going to have all these people immune. It's going to be like, you know, whatever 20% of or whatever 2 or 3% of 880,000 is. Yeah. They're not going to be gigantic numbers. And yeah, we can cohort people together. I'm thinking mostly of people who care for the frail elderly. You probably want them immune. Or we can use people who are immune to take care of COVID patients. But it's, you know, they're not going to be massive numbers. And we're not going to be able to like set schools up by COVID antibody status. They're not going to be enough people. So there probably will be a bump in the fall. And we're going to have to get on it and make sure. What's going to protect us the most?
Yeah, go ahead. Sorry.
What's going to protect us the most is other cities doing the right thing and moving to shelter in place. So we're not constantly reseeded by people from Dallas or Houston or wherever, where all of a sudden the population prevalence is 50% and there's ongoing transmission all the time.
So someone asked me the other day, is the end game here, let's say a vaccine takes a couple of years, is the end game here 100% of people have gotten it or not?
Gotten the vaccine?
No, let's say it takes a couple of years to get the vaccine. Someone asked, like, why wouldn't we all eventually get it? And I think your answer is that we're going to stomp out these embers through aggressive testing, contact tracing, and we don't need to get a herd immunity at 70%.
Herd immunity of 70%, which by the way isn't herd immunity. You have to get measles, it's 96%. That will come at a tremendous cost of life. And I think there are other ways to do it that won't result in 10 or 15,000 excess deaths. And you know, those are the stakes we're playing with now.
Yeah. All right, we're running out of time. Let's go around to everybody. And I think I asked last time sort of one lesson that you have learned in doing this now for, I guess, a month. I mean, I think of like COVID years like dog years now. It certainly does not feel like a month. It feels like a year. But, and if you were on last time, talk about something else, something that you have learned that you didn't understand about the disease, about the way we're responding to it, and whatever you want to talk about. So Matt, you want to start?
Sure. So I can't recall exactly what I said at this point last time, but I'll say it. But I'll say certainly in the last few weeks have reinforced my belief that we need to practice evidence-based critical care. That's core to this. There is a lot of push to try new things, to do different things, to view this as fundamentally different from other virally mediated ARDS, let's say. And I think that's a mistake. I think our focus really needs to be to do the things we know or are proven in the literature to offer benefit, and to follow the practices that we're comfortable with. I remain concerned by the desire to treat this sort of fundamentally differently. I mean, obviously there's some aspects of care we need to be very different about, certainly the way we protect our staff and protect ourselves and PPE, but I still think, as Annie mentioned earlier, I mean, we have a lot of evidence about how to manage ARDS now and how to do it to offer the most benefit. And I think we need to continue to do that and not get distracted by our concerns and by the hope that there's something else out there that will make this different. I think we need to really stay the course with that.
What's the most common anecdotal, non-evidence-based thing that you are pushed to do?
Well, I think I will say this has gotten some discussion in our group. I mean, I think there's a lot of discussion, for instance, about what the use of non-invasive ventilation strategies are in management of these patients. And people see videos of helmet CPAP and BiPAP being done in other parts of the country, in Italy and in China. I think there's a role, I agree with the WHO guidelines on this. There's a role for non-invasive ventilation and for high-flow nasal cannula in selected patients. And I think we need to take the same approach to other patients with respiratory failure and identify those patients for whom it's appropriate. And so if you have a patient with COPD who has an exacerbation we believe to be caused by COVID-19, then I think that's the patient we should look at for use of non-invasive ventilation. I don't think we should suddenly, because we've heard of reports from other places, have decided that we're going to put everybody in helmet CPAP. And hope that that's going to work for ARDS when we have evidence that would suggest that that's probably not the best approach. So that's just an example. And I'd say the same thing pharmacologically. Right now, as Annie said, there's limits on what we know, and I think we need to stay focused on getting patients into trials, but not exposing patients to the potential for harm, with the hope that somehow or another some medication will be beneficial. I think that's going to lead us down a path we shouldn't take.
Got it. All right, Brad.
Yeah, so I won't repeat last time. I focused on slowing down on human connectivity and empathy. And for human connectivity, the one piece that has rung true for me is the WHO has shifted away from social distancing to physical distancing, and the concept of the importance of social connectivity while maintaining physical separation. I think I'll highlight just two things. One is what I've learned operationally from our development of the respiratory isolation unit, since I'm getting a lot of emails from around the country about this. I'd say there's 5 aspects that I've taken away from this enterprise. One is the importance of shared goals and vision. The other one is adequate training and preparation of everybody who is involved in the unit. 3 is making sure that there's consensus for all policies, procedures, and protocols on the unit. 4 is the importance of seamless communication among peers and also bidirectionally between unit leadership and the folks on the unit. And then 5 is just all efforts to build a culture that's grounded on that shared vision, as well as a culture of love and mutual support. The other thing I'll just quickly reference is just three papers that have really stuck out in my mind that I just would call attention to. The first, for those of our colleagues who are on the front lines, really in battle. A paper was just published by Journal of Hospital Medicine called 10 Tips for a Crisis, Lessons from a Soldier, that was put out by retired Lieutenant General Mark Hertling, which I think is a very powerful look at how we in medicine can learn from our friends in the Army. The second article of 3 that I'd like to highlight is a paper called That Discomfort You're Feeling is Grief, put out in Harvard Business Review by Scott Baronato. And it draws from learnings from David Kessler, who co-authored the grief work with Elizabeth Kubler-Ross, and essentially discussing the notion of anticipatory grief that many of us are feeling before and during the waves of patients with coronavirus. And the final piece that I'll highlight, which was brought originally to my attention by a friend and colleague, Cindy Fenton, was a piece in the New York Times called The Moral Meaning of the Plague by David Brooks, which is just a powerful reflection on how to try to find a semblance of meaning through all of this human suffering. So those three pieces I keep on my desktop, and I'd highly recommend them.
Great, thank you. Sarah.
Yeah, I think I'll just highlight two things. One is medicine is very, very humbling, and practicing medicine during a time when we know very little about what we're doing, spending most of our time on, is humbling. And I think it's very important that we continue to learn and study what we're seeing so that we can better understand how to safely care for patients and prevent further infections. And then the other thing I'll say is I have a huge amount of respect for our Department of Public Health and the leadership in the city and the state for having made a call that seemed premature to many, and I think is saving lives.
Great, thank you. Thank you for highlighting that. I think that's there's no question that's right. Sirisha.
I'll highlight two things. I think doing a lot of the ethics work and thinking about triage and allocation, which nobody wants to do and no one wants to think about or even address the realities of. I've learned so much from colleagues about the importance of thinking very, very critically and thoughtfully about every decision. And that too, especially when you're making really tough calls from potentially value-based calls, then making sure that there aren't groups that are unfortunately discriminated against. And I'm very reassured by the conversations, especially across the UCs, about with the thoughtfulness in ensuring that our vulnerable populations are protected. And there's a lot out there about the disproportionate impact on certain groups of people. And I think that is something that we all need to pay attention to and also count our own blessings in that context. So the equity lens has been great. And I'll echo Matt's comment. We need to stay focused and just keep going and stick with what we're doing right now. And hopefully we'll never have to get to a place where we're talking about ventilators.
We will hope that we stay there. Last word, George.
I think we need to be really careful, really understand what we're doing in the population sense. Both Art Reingold, my equivalent at Berkeley, and I brought up the St. Louis experience in the 1918 influenza, which was very instrumental in driving a lot of these decisions. And Sarah's totally right. The health department, the mayor's office, the other counties stepped up to this in a way that was unexpectedly, I think unexpected in the broader state, and certainly is saving, I would say, well beyond thousands of lives and into the tens of thousands of lives. And then the other thing, just for your trivia books, next time you play hospital trivia, I think I'm the first pediatrician in the history of the world who's done both surgery and medicine grand rounds in the same week. So
very
you put that one away.
You will get that award. Let me sign off and thank you all for the 5 of you and the 4 before for an incredibly informative discussion, and it's fascinating. I think it's really important. I think we'll probably do a version of this in a couple of weeks. It feels like life is changing so quickly that there will be more to say. As I mentioned before, we will put this on YouTube hopefully later today. I will tweet that out later, and then it will go out through more traditional channels in other ways. I hope we can put up a slide that has some thank yous to the folks that have helped produce this and put it together. Alyssa, Lisa, Serena, John, and Kyle, thank you. It turns out that producing something like this on YouTube is a little bit harder than doing it in person, but thank you for all of that. And so thank you for joining us. And until then, please do what you can to stay safe. And thank you for all you're doing taking care of our patients. And we'll talk to you soon. Thank you.